is transcranial direct current stimulation, tDCS. tDCS is a form of neuromodulation that uses low direct current delivered via electrodes that just sit on the head, nothing invasive, keeping with the Welcome mission. Today, we're announcing a new collaboration with Plato Science to offer researchers and clinicians this neuromodulation technology to support your patient treatments and neuroscience research studies. Dr. Balder Onnerheim is the CEO of Plato Science. He's here with us today to share insights on this technology and how it can be used to support your work for research and clinical applications. In fact, he's going to share some facts on how tDCS may be used to support TMS patient outcomes and improve them and improve longevity. Also joining us here today is John Leadham, our VP of Research Products and Business Developments. John will be our guide for this webinar. Please add any questions you have into the chat. John will be moderating those, and we hope to be able to answer everything today. I need to read the following legal statement before we get started, just to keep our attorneys and regulators happy. Scientific content remains the intellectual property of the authors. This webinar is sponsored and organized by Magstim EGI. However, neither Magstim EGI nor its parent company, Welcome, engages in generating or editing scientific content presented. Inclusion in this webinar should not be taken as an endorsement of scientific findings by Magstim EGI. Please note the use of Magstim devices or EGI devices for other than the cleared intended use is considered investigational. With that, I'll turn it over, and I'm delighted to present Dr. Onnerheim. Thank you.
Let's see. Wonderful. Thank you so much, Ronnie. It's a pleasure to be here. I hope you can all see my screen sharing now. Perfect. Yeah, so it's always nerve-wracking when you're being introduced with a list of things that I will cover that I'm not sure if I will, so we might have to cover some of those points in the Q&A, Ronnie. So my name is Balder. I'm very happy to be here and talk about our tDCS solution in collaboration with Magstim. I think in all the years that we've been working with this, we've had a very close relationship with TMS practitioners, TMS researchers, and I'm very excited to finally have found the right venue to partner up with a TMS company to start a journey of being able to offer a more coherent system where TMS can be used in lab and tDCS can be used in an at-home context, which is where I see this very beneficial relationship between the two technologies. So the topics that I'll cover in the next 20-25 minutes or so, I'll say a couple of words about who I am, my background. I'm going to mention a little bit about tDCS. In my understanding, we have both clinicians, but also researchers partaking today. So apologies in advance if I'm starting on a too general level, but hopefully we'll get into a bit more concrete at the end. Also important to mention that since I'm from the engineering side of things, if we get into the very nitty-gritty science points, then hopefully we can do that as a bit more of a discussion. I'll talk about Plato Science as a company. I'll talk about the system that we offer. I'll get a little more into the detail about the science of tDCS. I'll do a comparison between tDCS and TMS, talk about the differences, the similarities, the interaction between the two. I'll quickly mention a bit about the regulatory. We are currently in more than 80 different countries, 80 different countries. So it is a very different per country, per market regulatory space right now. So I'll try to be more general. And then finally, I'll round off with a little bit about how we can learn more together about the relationship between tDCS and TMS. So just to give you my background, where I'm coming from. So originally I'm from Norway. I'm currently in Copenhagen, where Plato Science is based. I actually started my career, as a lot of Norwegians, in the military, ended up as an officer and spent quite some time on the Norwegian-Russian border. When I was there some 20 some years ago, it was a pretty boring place. Nowadays, it might be a little more interesting place to be. And it's a very extreme environment. It's all the way up north, where Norway sort of falls into Russia. And what I learned in these very harsh environments was a very big interest in the importance of good design and good equipment design. So that led me on to an engineering degree focusing on medical equipment design. And I've been working with everything from single-use plastics, urine collection bags, ostomy bags, etc., all the way up to the design of ambulance aircraft, so quite a big range in devices. Then I went on and did a PhD on the psychology of engineering. So I looked at different neurological processes that happen while you are designing as an engineer. And in my work with engineering psychology, me and some colleagues started getting a very strong interest in how we could use technology to impact the learning processes that were involved in the topics we studied. So that's where I ended up more in brain hacking hobbyist, I would say, which brought me onto Plato Science. And of all the different technologies we played around with back in those days, I personally found a very strong interest for tDCS, so transcranial direct current stimulation. As Ronnie mentioned, it's a very simple technology. It's actually quite old, you might say about 30 years, at least in research, some 1,000 years if you look at the use of electric eels to induce a state of electric imbalance to the brain. But if we look at the modern tradition and the core of tDCS, and of course this isn't the whole picture, but how it's normally explained is you have at least 2 electrodes. They're placed on the skull. Normally they use a wet sponge moistened with saline. You send a direct electrical current from one electrode. It will pass through on the surface of the brain and be picked up by the cathode. And what the general principles is that under the anode, you have an increased potential for activity. Under the cathode, you have a decrease. And this has been studied in a lot of different ways, all the way from neuron levels to digital modeling and everything in between. And I think at this point, it would be pretty radical to say that tDCS doesn't have documented effects on the brain. I think I met a TPEMF salesperson who told me that he didn't believe in tDCS. And to me, it's not something you believe in or not believe in. We can have lots of very interesting discussions about the details and the still open scientific questions. But I think the question of whether tDCS has measurable effects on the brain, I think that question is done. As I said, it's quite an old field. Most researchers will start by citing Nietzsche and Paulus, and they actually came from the TMS field, and they even used TMS as a way to demonstrate the effects of tDCS. So I think this famous study, the 2000 study, is probably the most important starting point for anyone interested in understanding the background of how TMS was originally used as a way of testing the effect of tDCS. And looking at the development over time, I think it's quite an interesting exercise we do sometimes to look at how different strand of research within non-invasive brain stimulation is developing. So here we've made a comparison of TMS, the green, tDCS, the yellow, PEMF, TPEMF, any type of micromagnetism studies in the red, and CES, so transcranial, the through the skull technology. It's the old Fisher-Wallace one. Sorry for even having it in here. The blue. And what I think is quite interesting to see here is how the research on tDCS has grown very rapidly recently, and at this point we're above 1,000 published peer-reviewed studies a year. And there are many reasons for this. One of the very important ones that we find very interesting is the possibility for doing large-scale studies. As I said, the technology is very simple. It's also quite a safe technology from a side effect perspective. And of course, most importantly, tDCS can be done at home, which means that you can do studies with very interesting time perspectives. The challenge, as I see it, and this is also what we found when we started working with tDCS now it's almost 15 years ago, was the form factor of the technology. So what you see here is the typical setup at the time. This is from 2015. So you have some sponges, often very colorful. They're strapped to the head with some type of ribbons. Every time you're redoing the same study on the same person, you need to redo your measurements, find the right straps. You see the cables, normally 2 cables connected to a type of switchboard that is manually operated, and then the results are often written down elsewhere or transferred from the device and onwards. And what we wanted to do initially was not so much to do the research. We actually started out by wanting to make it more accessible. And I think that is probably the most important recurring topic for Plato Science, is we want to make tDCS as available as possible to end users, to researchers, to clinicians. And in our view of it, the way to do so is to make robust, easy to use systems, easy to use as in at home for the person who actually used the system, but also easy to use from the researcher or clinician perspective in the configuration of the device and the use of it. So the very beginning of Plato Science, we simply started to design our own tDCS device. We took the key principles and did a lot of usability engineering with the end purpose of making a device that was plug and play for any type of user. And that work, after quite some years, actually culminated in the current device we have, which is currently on the market. It's called PlatoWork 2.0, which is a headset which comes collapsed and can be expanded and put on the head in different positions. The device has Bluetooth, it's rechargeable, and controlled by a smartphone application. So we sort of ended with this product platform that consists of a device which is rigid in certain ways, flexible in other ways, with an app to control it, which of course allows for remote monitoring. And I think this balance between flexibility and having a fixed setup is very important for us. We think that to make a good system, it needs to strike the right balance between those two factors. On one hand, we have the fully flexible system, so very similar to an EEG system. You have a cap with lots of holes, and then you put in your electrodes where you like them. You have cables that you can strap to an external device, so fully flexible, which of course allows for any type of experimentation, but it also limits a lot the flexibility, or excuse me, the fixed home use version. Then on the other end, we have the fully fixed setups where you have two electrodes placed in one physical device. It can be worn in one way. The electrodes are predefined as anode and cathode that can't be changed, and normally they also have, from a regulatory perspective, they have a predefined purpose, which is normally a single medical application. So what we try to do at Plutoscience is to find a place in between the two, so allowing a certain level of flexibility, and especially for researchers, a high level of flexibility, but make sure that it's very easy for the end user or the research subjects to put on the device and use it correctly in the same way every time. So the current product system, which we are launching and providing together with MagStim, consists of 3 elements. So it's the physical headset, it's the mobile app, and it's a web app for clinicians or researchers. And using the web app, the mobile app can be remotely configured to then provide different options for the headset for the end user or for the research subject. And the interesting thing with such a setup is, of course, that it allows for the remote monitoring, so you can follow up with compliance with patients or with subjects, but it also allows for things like sham stimulation, double, even triple blinding, etc. So this combination of a device with Bluetooth, a smartphone app that is connected to a dashboard for adjusting the setup, is what we think allows for this balance of flexibility to fixed designs. The current device has 3 electrodes. The standard setup, the device is used with 2 electrodes in the front, 1 in the back. So according to the 1020 system, that would be F3, F4, and P set. But by either rotating the device or turning it around, other areas can also be reached. And then, of course, remotely, we can control which of the 3 electrodes that are activated as anode, cathode, and of course, with a number of different sham opportunities. Today, the device has been used for a number of different purposes, everything from quite sort of practical applications in a more performance enhancement sense. So the Nissan racing team has done some very interesting work. Some of it is published already, looking at how to train new courses more effectively. But we also do research projects with a number of different universities to allow them to scale up the research and not be too limited by lab setups. So that was the company and the system. Conscious of the time, I'll start on the research part before moving on. But I think it's very important when we talk about TMS and tDCS to look at the main difference, which is for tDCS, we have both effects during the actual stimulation, so what we call instant tDCS effects, but we also have long-term effects. And I think for anyone who has followed the research field for a long time, I think we've definitely seen a shift from a very in session during tDCS, instant tDCS effect. So a lot of performance enhancement can be used tDCS to increase performance here and now. And while some of those studies, for instance, comparing tDCS to caffeine has quite good results, I think it's safe to say that these instant tDCS effect, which relies on changes to resting membrane potential, are at such a small level that it's hard to measure the effect of these, especially on things like performance tasks, in a single session. So what we look at, and what I think is definitely the where the whole field is moving towards, is the long-term effects of tDCS, which is long-term potentiation-like effects. And I think it's important to say it isn't strictly LTP, but the effects that are measured are seem to be behaving in the same way. So this is also then the main model for tDCS effects. And the underlying principle is that as we keep activating same neurons over time, then of course that will have the LTP-like effects that we are looking for. And one of the things that I find very interesting with the development in the field of tDCS is how this sort of single session focus changed into a 3-week, 5 times a week focus. And now we're starting to see much longer studies. And it's also starting to come out some quite good meta studies looking at how the effects actually seem to be increasing over time. So it seems to be across all these studies that longer studies have better effects, which of course speaks to these new devices like ours that allows for continuous, if that's 3 months, 6 months, 2 years, continuous use, and measure those effects over time. So it's definitely depression that has been the field that has attracted more and more attention within tDCS. And here it's very important to emphasize, I think it's back to Ronnie's introduction, that PleatherWork is not a device that is approved for treatment. It's a device that is approved for tDCS. So it's a generic tDCS device. It's not a depression device. So the studies that I refer to here are from other devices that are looking at depression as a function of time. And what we see here to the right, it's a large sample of 576 patients who received 6 weeks of stimulation. And as you can see to the graphs A and graph B, the effect size is clearly increasing as a function of time. We do a lot of research collaborations where we are not an active part. So we have researchers who are using our devices under the local ethical rules, ethical approvals to perform studies, and depression are on the list of those studies. I think I just want to show these two more for the references and how to put this in a careful way. So I think because tDCS is such a simple technology in itself, there aren't big differences between tDCS. I think when tDCS is done correctly, then as long as you reproduce the same level of currents in the same surface type electrodes, then you should expect the same effect. So I think showing which of the devices have been used is less important in this case. I think as long as it's comparable, the type of currents and electrodes, then I think it's safe to say that there's no secret sauce in tDCS in its basic foundational use. So in these two studies, researchers have, in a research study in Greece, compared tDCS and psychotherapy. In another, looked at improvement in depressive symptoms and in cognitive functions in a depressed population. And I think one of the very interesting findings in the second study was that it seems that as the improvement in depression symptoms improve, so do the cognitive functions. And this study was also controlled using repeated EEG measures. So quite an interesting prospect for future type of studies to also look at how improving one metric can actually have positive effects on others. Just some other references for those who are interested. Plato Science is involved in other type of work as well. For instance, some of you might be familiar with the Lotus, originally the limited output transcranial electrical stimulation 2017, which was a framework looking at the regulatory space for non-medical NIBs, you might say. And we recently partook in a project to make an updated set of guidelines, the Lotus 2023. We also do more theoretical conceptual work on different aspects of remotely supervised at-home TES. One example here, studied by Paneva. And finally, we're currently quite engaged in the changing regulatory space in Europe. I've also been writing extensively about this online, where the EU regulators have pulled together a lot of technologies that we think maybe shouldn't be pulled together. But I think I will get to that in just one slide. Yes, so getting to the end of my talk here, and very curious to hear any questions that have come in. We have this table that we normally show when we talk about the comparison between TMS and tDCS. And I think for me, the main difference, which is also the most important one, is TMS does have, I would say clearly, a bigger effect during the actual session. And that is positive in the sense that it's easier to measure, it's easier from a clinical perspective, but it also increased the risk profile. tDCS, on the other hand, has slightly smaller effects from every session, but oppositely, that also follows the risk profile. So I think that that balance of saying you have an in-clinic technology that is quite powerful, both in a positive and in a risk sense. And then you have an at-home remotely supervisable technology, which has a smaller effect, but also smaller risk profile. I did already mention this. So the most important part for us when doing research projects is to try to support researchers to tailor the solution to their research needs, but of course within the physical limitations of what tDCS is. Then I think also, without going too much into details with this, it can be a pretty big topic, but I think the regulatory aspect of tDCS is important. So historically, under previous EU regulations, so we're based in the EU, so that's what we take as our starting point. The regulatory space was fairly open, which was positive in terms of fast development and also quick to market, usability engineering, as I mentioned. But it also led to a very large number of devices with very, very strong claims. So what happened with the introduction of the MDR, the new regulative in the EU, was that they went very far the other direction. So they have now made mandatory medical regulation for any type of tDCS. So no matter what you use it for, that's under the MDR Annex 16. And quite recently, now about a year and a half ago, they went even further to saying that tDCS in the EU used for medical purposes is class 2A, while tDCS used for non-medical purposes is class 3, so similar class to a pacemaker. And that is the same for TMS. TMS is in the same reclassification. And one of the challenges that, of course, comes out of that is if you don't have a defined medical purpose, then it makes it hard for researchers to to use a device unless they use a class 3 device, and a lot of universities using class 3 devices for research is a quite different ball again than using a class 2 device. In the US and other markets that are following same or similar framework, there are currently no devices that are clinically approved for tDCS. There are lots of breakthrough designations, so devices that are in the process of seeking to become the first FDA-approved device. But the interesting thing is that the amount of current used in tDCS sits below the thresholds normally applied by the FDA to have mandatory regulation. So today, tDCS is not mandatory regulated in the FDA, which means that tDCS can be used without classification as a device as long as no medical claims are made. Elsewhere, the general rule, as I said, we're in a 80+ market, so I think the general rule is that except from certain markets like South Korea, Taiwan, Japan, that has a very specific categorization for tDCS, other markets follow either the EU, the MDR, Annex 16, Class 2 versus Class 3 approach, or the FDA. Only medical claims for tDCS will be regulated, while non-medical claims devices can be used freely for instance, research work. Coming to the end of my presentation today, if you're interested in learning more, of course, happy to answer questions here on the Q&A, but Plato Science does offer a TS certification, so for any researchers or clinicians who's interested in learning more about TES, we have a 3 + 3 hours, so 6-hour-long certification that focuses much more on both the scientific foundation, but also the current research within TS. I'm not sure, John, so we're currently setting up a multi-center study with MagStim, but I'm not sure how much. I think if any researchers who are partaking here are interested in potentially being part of a multi-center trial that we are currently setting up, then we haven't started it yet. There are still room for more, and I think it will become a very important milestone in showing the beneficial relationship between TMS and tDCS. So with that, sorry for going over time a little bit, but this is a dear topic of mine. So thank you all very much for listening. Over to you, John.
Yeah, thanks, Baldur. That was you can hear me okay? Yeah, that was a fantastic introduction to Plato and tDCS for everybody that's in on the call here. Actually, to your last point, that I had that question come in. The question was, do you see tDCS working hand in hand with TMS, so possibly pre-TMS or post-TMS to how did they word it, to kind of lock in the effects of TMS, or to induce some plasticity before TMS. What are your thoughts on that?
Yeah, I think we've sort of listed a number of different ways that we see interaction between TMS and tDCS, and I think the priming idea is definitely not new. I think the studies or the study design for it is obvious, but it hasn't been done, I think, enough work yet to say, can we actually improve the effect of TMS by doing tDCS, maybe even at home in the morning before going to the clinic, so you save clinic time. Another way to use it that we find very interesting, also a lack of research so far, is to start patients on tDCS before they can get into TMS. So if you have a waiting list, for instance, for patients here in Denmark, the government is currently testing out a TMS offering as part of the public healthcare system, and the waiting time is so long that we're now looking at doing sort of waiting line tDCS, you might call it. Another one which I personally probably find the most interesting is relapse prevention or maintenance after successful TMS. We're currently carrying out a study with 2 Danish hospitals who use TMS. And the last one, which is another especially for a practical point of view, is to replace certain TMS sessions. If you have patients who can't meet in at the frequency you would like to do your TMS, or they're for some reason not able to come for a session, that they can do tDCS as a bit of a replacement. So instead of bringing the patient in 10 times, you might bring the person in 6 times instead, and then do tDCS top-ups in between. So I think on a hypothetical level, there are lots of these interesting cases, but due to, I would say, the lack of the type of systems we have, where it's very easy to give one of these kits to a patient and say, you know, if you can't come in one day, then have a session with this in between. So I think now we have a setup that allows for testing and verifying all these different hypotheses that I think from a research scientific perspective makes perfect sense. It's just unfortunately not well studied yet.
Right. I liked your slide that compared tDCS and TMS. It prompted a question that most of the tDCS studies, how do I word this right here? So TMS people, and you touched on this, TMS people are like, well, that doesn't create an action potential, so is it really doing anything? And you know, that type of thing. Do you think that some of the research studies that tDCS has been involved in the past, where that they just didn't get really fantastic results, they showed a signal, but the results weren't that great, are because they were basically templating themselves from TMS studies where they did 20 or 30 treatments and stopped, and tDCS tried to copy that model, whereas maybe they should have gone out 3 months, 6 months, or longer to see what effects were there. I think you touched on this a little bit during your talk, but could you maybe expand on that a little bit?
Yeah, I think it's a very good and very important point, that because tDCS almost came out as a spin out from TMS, we have a lot of legacy in also in things like safety screening and the precaution lists, things like that come from TMS, but there's no logical reason. We do now actually see a bit of interaction back. So for instance, in the new EU regulations, skin burns is mentioned as a possible extreme effect of TMS, which just makes absolutely no sense, but that comes from tDCS. So I think there are some incorrect exchanges between the two because they are so closely related. When it comes to the original studies, it's definitely, as you say, a challenge of expecting the similar effect. So you think you can sort of redo your TMS paradigm with the tDCS device and get the same effect. And then the early single session or dual session, one sham, no sham paradigms did yield sort of very back and forth results. And I think that has definitely punished the reputation for tDCS for quite some while. As I said in the beginning, I think we're past that point now. If you look at the the amount of evidence, we're sort of past that. But I definitely think that was a problem in the beginning, and it's a hard-lived myth, I would say.
Thank you. Question from the field here. There are commercial products in the market claiming that they can stimulate non-invasively the brain with tDCS using a number of EEG channels. In this way, they can stimulate specific brain areas. What is your opinion about this?
Yeah, so there's a patented protected technology called HD tDCS, and I assume that's what Christos is pointing to. There are lots of different approaches to how to put this, to how to distribute your current through electrodes. So that the most rudimental and also the most commonly used is to have I have one of ours here. So you have basically one fairly big electrode that sits in one area, and then you pick up the current somewhere else. And there's been a lot of studies and more and more recently looking at what happens if you have like a center electrode with 10 small, more EEG style, 16 square centimeter, for instance, or even smaller electrodes around. And it's a much smaller research field, definitely, and I think yeah, it's always problematic with the patenting in that specific space. But I would say there's a huge potential in modeling, especially for individual targets. So if you have a patient, you have a high definition fMRI scan, you identify a given target, you can do digital modeling where you sort of define with 16 electrodes and say, okay, from the model, we're most likely impacting the given target in the way we want to impact it if we have electrodes in this very specific, and then you use reproduction on the skull to place the electrodes, and then it does make sense. But for multiple small electrodes to have a predictable effect, you need to be very specific about which region you want to target in the individual.
Another question here, is tDCS more effective while doing a cognitive or motor task, or is it better to have the patient relaxed and not engaged in the performance?
Yeah, it's I love that topic. So traditionally, tDCS was largely used as a monotherapy. So there's a lot of evidence where you basically do nothing, or you do a very simple monotonous tasks, could be reading or even looking at sort of images. And there are very good results from not sort of invoking other type of cognitive activity. But as more and more combinational studies are coming out, even combining 2, 3, 4 different modalities, I would say it's clear that if you pair tDCS with the right type of cognitive activity, then yes, you will have a potential stronger effect. The challenge is, of course, with this challenge that we've been talking about, that you do need a lot of sessions to get the LTP-like effects, then it's quite hard to test completely novel paradigms. So what we see is that we expand the paradigm slowly rather than trying completely new ones. But my sort of personal take on it is, by using the right type of cognitive intervention, you can definitely increase the positive effects we see from tDCS.
Okay. More of a technical question. Having had my hands on your device and the app, I love the device. I love how easy it is to control. The one question I can see that I'm going to get when I'm talking about this to people is, because of the connection straight to Bluetooth and up to the web, where it can be controlled from the web access, what is in place to make sure that all the private details are kept private?
Yeah. So in our current setup, we actually keep the device data separate from any type of personal database. So our system's actually based on a patient ID, which is then kept separate. So we don't know who our research subjects are, and it's the researcher who has the possibility to pair that information. So that's our current take on it. For some of our clinicians, they do ask to be able to pair it with patient management systems, and it is something we are working on, but the type of problems changes by some magnitudes the second that you pair this data. But of course, it's quite different. tDCS data just tells how a device has been used at what time, which currents, any challenges with connecting the electrodes. It's not like EEG data, for instance, which of course has some type of biological identity of the subject. So in that sense, for anyone who's used to working with patient data and EEG, that's very different. Yeah, different scale of the problem.
Okay. One question that I get from time to time, and I think it's because of our crossover with EEG, of course, is everybody likes this idea of dry electrodes, and I can work very quickly, set things up. So I've had the question, why not dry electrodes like in EEG for using with tDCS? I'm sure you can do a better explanation than I can, but
yeah, I think it's always been a bit of the holy grail, both for EEG and now also for TES. And I think what our take on it is to try to achieve drier but not dry electrodes. It's a different type of problem compared to EEG, but because we need quite a lot of electrical currents to pass through the skin, and all the risk or safety profiles really of tDCS is on the passing of the currents. And in a lab setting where you have full control, you can actually do pretty okay full dry tDCS, but when doing it in an at-home context, then the risk profile changes so quickly when you don't have any type of moisture to make sure that the current distributes evenly. And of course, John, for you and for myself, lots of electrode positions are pretty easy with no hair in the way, but also getting through hair, so doing electrode placements, especially on the back of the head, moisture just adds so much to the safety. So it can be done, but I wouldn't say so. We use salt water in our electrodes, and anyone who likes to go for a swim wouldn't bother to or wouldn't mind having a bit of salt water in their hair. So I think that's also compared to, for instance, EEG gel. But as anyone familiar with EGI has the same approach with a sponge and salt water.
right. Another question just came in from the field. You may have touched on this briefly. Does the placement of the anode and cathode matter for tDCS due to the lack of focality and specificity?
Yeah, it's another very, very important question, and it matters less than in other fields. The effects that we're looking for are sort of whole brain surface area. So if the electrodes is a little sort of different in one person to the next, as long as the electrode placements are consistent in the same subject over time, so you are sure you get the same effect every session. And I think that's, for me, the reproducible in the individual is probably more important, because if you every time you put your device on, the electrodes will be slightly different places, then the currents will take slightly different paths, and this long-term effects that we are looking for will actually not happen. So I think it's more the consistency in the individual over time that's important, more than sort of measuring the exact millimeter placement in accordance with, for instance, the 1020 system. Of course, electrodes that are placed too close together, for instance, will be likely to just have a direct connection on the skin. So there are other interests, but I think compared to other technologies and TMS, of course, specifically, the exact angle or the exact placement have less importance, because the effects we are looking for aren't as focal.
The headset that you've designed, I find really clever in its design. But how do you make sure you do get that repetitive placement each time?
Yeah, so the idea with the physical, so the hard frame is to ensure that the electrodes end up in the same, and then there are sort of adjustments. So you have your size, and then we use a biological measure. So we actually use the eyebrows and forefingers of the patient. So there is a way for them to sort of measure, so it's the same placement every time they put the device on. Of course, if it's motor stimulation, it's a little different how you then secure that the headset is in the same position every time. But it's definitely a trade-off with a hard frame compared to a soft cap, and there are as you all know, there are devices out there that have the soft caps instead. And for me, it's definitely harder to ensure the same position every time with the soft cap compared to a hard device.
Maybe two more quick questions here. As this device is used at home or away from the research lab or the clinician's clinic, whichever, obviously there's been a lot of thought into the safety measures with regards to tDCS. Can you go a little deeper into what safety measures are in place for use for subjects that are outside of the lab?
Yeah, absolutely. So there are lots of sort of safety limits and safety practices. I think, on one hand, you have it shouldn't be possible to connect the device to main current. So you shouldn't be able to plug it in the socket and have it at the head at the same time to sort of limit the extreme risks. But in the device itself, and this is quite industry standard, things like limiting the battery size. So even if the whole battery would sort of discharge at the fastest discharge rate, you wouldn't have enough power to get above the thresholds. We have lots of hardware fuses and sort of off-take circuits. So if there would, for any reason, come too much current into the device, it wouldn't reach the electrodes. We have firmware limitations, which is a whole different, where you sort of put limitations and monitoring into the software that runs on the device. And then, of course, in the end, also reporting any type of side effects and risks and any sort of unhealthy use patterns. So, for instance, if a patient always is running sessions at the very border of what the device allows, then there's something wrong in the setup. So it's also a bit of overtime monitoring, which we communicate that information to the researchers.
Okay. One last question here. I scrolled down and it wasn't on my screen. It's here, but it's a good one to ask. For home use, can it be programmed to set up, for example, 14 or 15 stimulations, and can you also create a minimum interval between those stimulations to prevent subjects from overstimulating themselves over that period of time? And can a user go in and check and see what quality was the stimulation? I suspect from an impedance perspective.
Yeah. So all these features are available in our system. So, and these are, of course, interesting and important safety measures. So, for instance, you can say a patient should only be able to do 10 or 15 sessions before the device will be deactivated, and they will have to meet back to the clinician and be assessed before they can continue use. How many sessions in a day, how long the sessions can be. And also, one thing is you can do hard stops, but you can also have a notification warning system where you get notified whenever a patient is using it more than prescribed. So there are also levels to the blocks.
Great. And we're coming up on 1 o'clock. I'll add one more question. I was going to give you a choice of questions. The biggest challenges or what excites you most about tDCS? You pick.
Well, I think what excites me the most about it is the endless list of different medical conditions that it's currently being tested and used for. It's just incredible, all the way from ADHD and ASD in children and all the way up to sort of Alzheimer's, dementia. If we include tACS, the sister technology, it seems now that we have these systems that where we can scale and do long-term studies where people do daily or even 4 daily sessions, schizophrenia. It's such a big potential now that we have the platforms to do it, and the research is taking off. So I'm just really looking forward to, in 5 years' time, to see in which of these conditions or situations where it is as beneficial as it is looking right now, because it has the potential to change the health outcome for very large populations.
And just to add to that, the web client that you have set up, I think makes this very easy to run large group studies, large numbers in the group, at an economical cost.
Yeah, that's accessibility. Let's make it easy to do this on scale.
Yeah. Well, thank you very much for your presentation and answering all those questions. This has been fantastic, and we look forward to getting this product out and into the field very quickly.
Absolutely. Thanks for having me, and thanks for everyone who listened and asked questions. And of course, feel free to reach out to me and/or Plato Science if you have any follow-up questions.
There are a couple other questions that we will email answers out to.